Good morning, everyone, and we will be starting this session, and welcome to the satellite, including, of course, those at home joining virtually. We're delighted to have you at least in the room in spirit. We wish you were in Montreal, but it's wonderful to have you anyway. My name is Linda Gale Becker. I'm the director of the Desmond Tutu HIV Centre at the University of Cape Town, South Africa, and a former IAS president. I'm joined today by Dr. Sarah Masiuko, who's head of HIV prevention and adolescents and young people program at the National AIDS and STI Control Program in Kenya. It's wonderful to have you, Sarah. And together we'll be chairing this session. So sit tight. We have a really exciting program. And today, particularly as we consider and congratulate Botswana again for their 95-95-95 amazing landmark on our continent, many countries will be hopefully moving to that point. But now is the time that we really do need to turn our attention in real enthusiasm towards primary prevention. HIV testing will need to be reoriented to serve a sero-neutral approach, ensuring linkage and engagement to both prevention and treatment programs. Sadly, PrEP scale-up has been slow. It was 10 years anniversary of PrEP just a couple of days ago, and yet less than 1 million people had started PrEP by 2020, far behind the target that we had set ourselves for that date. Despite the risk of scale being further hampered by COVID-19, we saw an increase in scale-up in 2021, which is, I think, something we should congratulate all of you for. We saw 1.9 million people started on PrEP by the end of 2021. Today, we will hear how differentiated PrEP delivery helped to make that increase happen. The new target of 10 million people starting PrEP by 2025, just 3 years away, is unbelievably daunting. And we really do need new strategies to help us achieve that target. So this session launches 2 very exciting technical briefs that we hope will support that scale-up, leveraging differentiated service delivery approaches we've gained great experience on the treatment side, and we're now bringing into prevention. WHO will be introducing their update to the 2017 PrEP implementation guidance. We will be introduced to updates in CAB-LA recommendations, starting and stopping PrEP, PrEP and hepatitis B and C, HIV self-testing use, and most importantly for this session, use of differentiated PrEP service delivery. The International AIDS Society and its partners have worked to develop a brief to support countries to develop PrEP differentiated service delivery guidance. And here I want to acknowledge Anna Grimsrud and the team at IAS for the work that they've done in this regard. Thank you. We appreciate what you do. It sets out the key considerations in developing policy guidance for differentiated PrEP service delivery. We will then hear from 3 innovative countries how they have used differentiated PrEP approaches to scale up PrEP from Kenya, Brazil, and Thailand before opening our panel discussion. And here too, I think it's important to acknowledge, and I want to thank the World Health Organization team led by the awesome Rachel Bagley, just for being absolutely on the ball in terms of, I know, CAB-LA is hardly out the door, and we're already having recommendations. So I want to just, applaud the team for moving this forward so quickly. Well done. And now I'm going to hand over to Sarah.
Thank you. Thank you so much, Professor Gale. So I think we do not have any conflict of interest to declare. So let me introduce to you the co-chairs and presenters for this session. As mentioned, I'm Dr. Sarah Masiuko. I am heading the HIV Prevention and Adolescent Young People's Program at the National AIDS and STI Control Program in Kenya. And I'll be co-chairing this session along with Professor Linda Gale Baker. Our first speaker will be Heather Marie Schmidt and Robin Schaefer. Robin works on PrEP for HIV prevention for the Testing, Prevention and Populations Unit of the Global HIV, Hepatitis and STI programs at WHO. And Heather Marie is Regional Advisor for Pre-Exposure Prophylaxis, jointly with the UNAIDS Regional Office for Asia and Pacific, and the HIV Testing, Prevention and Populations team at WHO, Global HIV Hepatitis STI program. They will be presenting on the launch of the WHO technical brief on differentiated service delivery for PrEP. And next we will have Ms. Lynn Wilkinson, who's a technical consultant with IAS and a research associate at the University of Cape Town. Lynn will present on the importance of DSD for PrEP while highlighting lessons learned from COVID-19. Our fourth speaker, as you can see here, we initially had Dr. Kenneth Ngure from Jomo Kenyatta University, but it will be presented by Katrina Ortbland from the University of Washington. And Katrina will present on adapting the when and where with innovations from Kenya, which is my home country. Then we will have Ana Francisca Colling, who works at the Ministry of Health in Brazil, and she will present virtually on adopting the WHO innovations from Brazil. Ana is a manager of the National HIV Coordination at the Department of Disease and Chronic Conditions and Sexually Transmitted Infections. And last but not least, we will have Naruk Japon Thamajaruk, Senior Program Officer at the Institute of HIV Research and Innovation in Thailand. And she will present on adopting the what innovations from Thailand. And then we will be followed by a panel discussion. And the panel discussion, the presenters will be Hasina Subedar, a Senior Technical Advisor at the National Department of Health in South Africa, and John Danvik Rosatino, Program and Innovations Director of Love Yourself in the Philippines. So we're looking forward to an exciting session. That's what we will be going through for today. So we will then have some time for questions at the end, and we want to ask that you submit your questions via the online platform and engage in the sessions via the social media. And I think we will now kick off and start our session with Heather Marie and Robin. Welcome.
Hello, everyone. I'm Robin, and I have a great pleasure to be here today. And I indeed feel very privileged that it was very easy for me to come here, while other people who were meant to be here were denied their right to attend the conference. So today I can speak with great pleasure to this technical brief that WHO is launching on differentiated and simplified PrEP service delivery. And I will do this jointly with Heather Marie Schmidt. We declare no conflicts of interests. Just very briefly as background, as the chairs of this session mentioned, there has been quite an impressive scale-up of PrEP despite disruptions by COVID-19, as you can see on the left-hand side. But just putting this in perspective, also as said before, we are very far off the target globally for 2020, which was missed by about 2/3. And you can also see how far we are away from the new target for 2025. And this is where we think at WHO this technical brief comes in, because it is aiming at supporting differentiated, simplified, demedicalized, and comprehensive PrEP services that can support uptake, persistence, and effective use of PrEP, maintain quality and safety of services, and thereby support the achievement of our global goals. This technical brief, which you can find online, is focusing on oral PrEP because, of course, that's where we have most evidence and most experience. But as mentioned, WHO, as of yesterday or the day before, recommends also offering HAP-LA as a new PrEP option. And also remind everyone that last year, WHO recommended offering the depipping vagina ring to cisgender women at risk of HIV. So there are specific considerations for these other PrEP products in the brief. And in the next few minutes, I'm just going to rush through the high-level topics that are included in this brief and just point out some key points for each section. The guidance includes some new messages and guidance on starting, using, and stopping PrEP, and focusing on oral PrEP, which are summarized here, and I'm not going to go into much detail, but a key message is that event-driven PrEP and the eligibility for event-driven PrEP has been expanded to include all cisgender men and trans and gender diverse people assigned male at birth who have sexual exposure to HIV and are not taking exogenous gender-affirming hormones. And we think that this has the potential to expand this option to many more people who are no longer required to identify as MSM as before and had to disclose their sexual orientation or key population status. All other populations not eligible for ED-PrEP, there's some change in the guidance too, that we are now saying that you can start oral PrEP with 7 doses over 7 days and then stop with 7 doses, again simplifying the previous guidance on stopping PrEP. Finally, a hepatitis B virus infection is no longer considered a contraindication for event-driven PrEP, again removing a barrier to this option and hopefully making it more accessible. Hepatitis B and C are indeed something featured in this brief quite heavily because we believe that PrEP services offer an opportunity, a unique opportunity in fact, to address these multiple public health issues. And that's really something we're emphasizing in this brief, that we should aim for considering providing comprehensive and integrated care. And again, not going into details, but the brief encourages programs to test for hepatitis B virus once around the time of initiation. So that language is important because it simplifies the approach a little bit. You don't need to actually do it at initiation, but aim to do it around, so within, say, 3 months. And similarly for hepatitis C, we suggest and strongly encourage to test once around the time of initiation and every 12 months thereafter, where PrEP services are provided to a population at high risk of hepatitis C. And I emphasize again that both hepatitis C and B infection are not contraindications for event-driven or daily oral PrEP use, as well as the depipping vagina ring. There's new guidance included on kidney function monitoring, which we hope will remove some barriers to PrEP implementation and adopts more of a differentiated view on risks for impaired kidney function in oral PrEP users. In particular here, the key point is that kidney function measurement can be considered optional among individuals at very low risk of kidney function impairment, so those under the age of 30, young people, which we know makes up a big proportion of PrEP users, and of course those who have no comorbidities. But it can also be considered optional among those aged 30 to 49 who don't have comorbidities depending on resources. And really, if kidney function measurement is implemented, it can be done around the time of initiation. Again, it doesn't have to happen at initiation. Self-testing, there's is very exciting implementation of self-testing for PrEP that has been accelerated during COVID-19, and we will hear more about that today. And the technical brief recognizes that HIV self-testing is an additional testing choice that can complement existing strategies for oral PrEP and the depipping vagina ring, reduce clinic visits, make services more acceptable to users. But the brief also recognized that there are quite significant research gaps when it comes to HIV self-testing supported PrEP services. And with that, I hand over to Heather Marie.
Thanks, Robin. We are passionate about the importance of differentiated services for PrEP. They can make PrEP more acceptable and accessible and support PrEP uptake, persistence, and effective use. And this is because differentiated services for PrEP are person and community-centered. They are adapted to the needs and the preferences of the people who would benefit from PrEP. In the technical brief, we focus, as Robin said, we focus on the building blocks of where. So we're talking about service location, who, the service provider, and when, service frequency, as well as what, that service package. And it is important that we, as we begin to implement CAB-LA, that we ensure that we do it alongside, and these very much throughout the continuum of PrEP use, as well as between PrEP products. As Robin mentioned, our experience to date has focused very much on the example, and our examples focus on oral PrEP. But the dapivirine vaginal ring is extremely amenable to differentiated service delivery models, perhaps even more so than oral PrEP. And it is important as we begin to implement long-acting injectable cabotegravir that we ensure that we do this alongside oral PrEP and the dapivirine vaginal ring as an additional choice, that we do not remedicalize PrEP, but rather that we find ways to deliver it within the same services, simplified and differentiated. We have amazing examples presented later in the session on the specific building blocks, so we won't go into the case studies that we've included in the technical brief, but we wanted to quickly address some of those key considerations under each of the building blocks. So under where, the things that we're really looking at, and it's perhaps the most obvious of the examples that we have, is community involvement. We need to make sure that there is government support and policy that underlies and provides support for how we can differentiate and provide models such as pharmacy-led PrEP, that we have mobile PrEP, that we have telehealth for PrEP, that the logistics systems support this, that there is adequate infrastructure. Clinical oversight and referral pathways are crucial to make sure that there is that integration, data systems and person-centered and integrated services. Under WHO, and we're talking about service providers here, task sharing is an incredibly important part, and it really is tied up with this. And so it's really making the best use of the available human resources, not always defaulting to a clinician or a physician, but really looking at the cadre of healthcare providers, including physicians, nurses, pharmacists, clinical officers, and trained and supervised peer and community healthcare workers, because each has a unique role and can provide amazing benefits towards the system. Acceptability of provider types to the PrEP user will be important in deciding which of these to use, and making sure that there's a registration and regulation of all of these provider types, and that the training and accreditation and systems support this differentiation. When and what includes making sure that the systems really do incorporate that dynamic use of PrEP. People start, they stop, they restart PrEP, and our services really need to make sure that we are focusing on how messy PrEP use is rather than trying to fit people into neat little boxes, because life is not like that. And needs to be client-centered. Package must be integrated, and co-delivery. So this will vary very much depending on the individual, so tailoring it to the individual. Some people just want PrEP, others will want a much more comprehensive service. So with that, I want to thank my colleagues at WHO, particularly Robin Schaefer, who led this process, as well as Rachel Bagley, acknowledge everybody who contributed to the technical brief, there are too many to list, and flag that we will, this is a whirlwind tour, there will be a webinar on the 25th of August, which will go into much more detail, so check out our website, the Global PrEP Network for WHO. Thank you.
Welcome, Lynn.
Good morning and welcome. I'm Lynn Wilkinson from the International AIDS Society's DSD initiative. I'm not seeing enough coffee, but I definitely think you need coffee for us to get through the exciting world of DSD in PrEP. The COVID pandemic provided and continues to provide us with many lessons about the critical resilience that DSD approaches introduce into HIV programming. Many countries endorsed emergency provisions early in the COVID-19 pandemic, leveraging DSD approaches not only for treatment, but also for PrEP. And even where countries didn't formally do so, healthcare providers did to ensure that people were able to manage their prevention needs. PrEP service delivery was simplified and decentralized, with reduced health facility interactions and community delivery of longer PrEP refills. It was importantly demedicalized with a reduced required service package, which enabled lay providers to dispense oral PrEP refills. And we saw the scale-up exponentially increase despite the COVID interruptions, as you see on the slide. The most common response from countries was to allow 3 monthly clinical visits and PrEP refills combined. Some countries from the first PrEP initiation visit, but most countries from the first follow-up clinical visit a month later. We also saw an increase in the use of virtual counselling and psychosocial check-in and the provision of HIV self-tests with PrEP refills so that people could test themselves at home. We saw an increase in peers distributing PrEP refills at community sites, also directly to homes or through courier services, and outreach was provided in communities to provide PrEP initiations and follow-up clinical consultations. This published example showed how shifting from monthly clinical consultations and drug refills for sex workers, female sex workers in Zimbabwe, to 3 monthly with virtual support from peers increased uptake. The blue trend line shows how PrEP initiations dropped nationally, but then picked up very quickly. See how the orange line showed the scale-up of this approach to female sex workers that drove the recovery. COVID-19's DSD responses gave a big kickstart to PrEP scale-up. Importantly, this is the beginning of leveraging DSD approaches, not the end. While different, there are many similarities between people using ART and people using PrEP, and we have to consider how to further reduce healthcare burden associated with PrEP use if we are to increase access, uptake, and effective use. Here you will see the building blocks for DSD for HIV treatments: the when, service frequency; the where, service location; the who, service providers; and the what, the service package. These started similarly to PrEP, with monthly combined clinical consultations and drug refills run at health facilities by doctors. These evolved to provide for more flexibility and reduce the healthcare burden for the person on treatment in the WHO 2016 guidance. And in the latest revision, recommended ART refills and clinical consultations 3 to 6 monthly, preferably 6 monthly, with some countries now going beyond these guidelines and endorsing annual clinical consultations as our evidence increases. Longer refills and further spaced clinical consultations facilitate the implementation of more out-of-facility models and peer or recipient of care-led models. As we increasingly grapple with disengagement from HIV treatment, especially early after starting ART, qualitative evidence is exploring people on HIV treatment struggle with engagement, and strong preference for increasing the flexibility in visit schedules to support their engagement when work, social responsibility, and other demands result in high mobility and competing time and financial demands. Similarly to PrEP, there have been years of concern over the outcomes impact of reduced clinical interactions in person with people on ART. But we see here from the PEPFAR-MER data that increasing ART refill lengths, including to people not yet established on ART, as was done during the pandemic, did not result in a drop in viral load coverage or suppression. PrEP and ART management are not the same, but it's likely that the people using PrEP and taking ART have more important similarities than differences. The more we empower peer and self-management, including stopping and restarting PrEP, the more impact PrEP will have on the HIV epidemic. I'm now going to To support DSD utilization in PrEP services, it may be helpful to briefly go through 4 fundamental DSD approaches that will support PrEP. Firstly, it is important to separate the initiation or reinitiation phase from the continuation phase. The initial phase allows for more comprehensive clinical assessment, education, and counseling support to set the stage for reducing this during the continuation phase. The initial phase can be up to 3 months, but could even be shorter, starting immediately a month after starting PrEP. Secondly, the continuation phase envisages alternating drug refill or injection administration only visits from your clinical consultation visits. This enables refills closer to home, work, and school. Here you will see the light blue dots indicating refill or injection-only visits, alternating with your orange dots, which are your clinical visits. Thirdly, the initiation and continuation service delivery phases are broken down into core service components. Here you see the initiation phase made up of assessment for and offer of PrEP after testing HIV negative. Then the PrEP initiation or reinitiation component. Understanding that people using PrEP stop and start frequently, the reinitiation component is likely different from the first initiation, with an abbreviated service delivery package supporting more flexible locations and providers for reinitiation. And lastly, initial follow-up, which as already said can be single or multiple visits after PrEP start. The continuation phase is made up of separate PrEP-only refill and clinical consultation visits. Lastly, the DSD building blocks need to be considered for each of the core PrEP service components: the when, the where, the who, and the what. These building blocks are strongly interdependent and need to be considered holistically. Where clinical visit frequency remains 3 monthly and based at health facilities, out-of-facility peer-led model options will remain limited. PrEP DSD advancement and expansion will be improved by the development of clear national DSD PrEP guidance. This guidance can be included in PrEP clinical guidance or DSD guidance across the cascade, guiding implementers on service delivery options available, who can prescribe PrEP and provide repeat scripts, who can distribute PrEP refills and administer PrEP injectables, where can a person collect their refills or have their injections administered, how frequently must a person for PrEP be seen for a clinical consultation, and what is the minimum package of care at follow-up visits. IAS, with guidance and input from global agencies and implementing partners, has developed a technical brief setting out the key considerations in developing policy guidance for PrEP DSD. You can see the link here. The brief sets out 8 key policies for differentiated PrEP DSD guidance, including service delivery considerations by PrEP method, duration of intended PrEP use, suitability assessment for less intensive PrEP DSD models, the usefulness of defining nationally supported building blocks with example DSD models. It further includes a draft of the policy for each key area for consideration and for country adaptation. Here you see an example 6, which provides a possible nationally supported building block on the WHO, the service providers who provide each service delivery component. Here you see the Policy 7 template showing one of the 9 PrEP DSD model examples for management during the continuation phase, in this case using community points. These considerations and examples will be updated as PrEP continues to evolve. We hope that countries will find this useful. The key takeaways from this presentation are that WHO strongly supports DSD approaches for PrEP. Scaling PrEP depends on implementing reduced intensity DSD models of care. PrEP implementers need country PrEP DSD operational guidance, clarifying PrEP service delivery building blocks. The PrEP landscape is evolving quickly, which will impact PrEP DSD. But let's adjust as we go. Thank you.
All right, good morning, everybody. My name is Katrina Ortblad, and I'm an assistant professor at the Fred Hutch Cancer Center in Seattle, Washington. And I'm presenting this research on behalf of my colleague, Dr. Kenneth Ingure, the Dean of the School of Public Health at the Jomo Kenyatta University of Agriculture and Technology in Kenya, who unfortunately could not be here today due to some visa challenges like so many other attendees of this conference have experienced. So the presentation today is we're presenting some work that we've been doing on differentiated models of PrEP service delivery, specifically innovations to adapt the when and where of how PrEP is being delivered in Kenya. Right now in Kenya, the primary way PrEP is being delivered is at accredited healthcare facilities, specifically most often public healthcare facilities. And to initiate PrEP in Kenya, you go to these facilities, and then you have to return every 3 months to receive quarterly clinic-based HIV testing to detect potential breakthrough infections. However, there's a number of barriers that exist with this model of clinic-based PrEP delivery, including stigma associated with visiting these HIV clinics within the facility, especially if you're not living with HIV, limited hours of operation, long wait times and travel distances to these facilities, and a lack of privacy at these facilities, often associated with overcrowding and the provision of HIV-specific services. So as we've been discussing, differentiated models of service delivery have the potential to help overcome some of these barriers to facility-delivered PrEP care in Kenya, including the what, who, where, and when of how services are delivered. So the what being whether or not you're delivering HIV testing, PrEP initiation, or an adherence support intervention. The who being potentially shifting services from PrEP providers or clinicians to lay counselors or community health workers or peers. The where being potentially shifting services from public facilities to community-based settings or private pharmacies, and the when being shifting services from monthly delivery to quarterly delivery to every 3 or 6 months. This is a chart or a table that shows the standard of care for PrEP service delivery in Kenya along these 4 differentiated service delivery building blocks. And what you can see is that PrEP is primarily being delivered at accredited public facilities by healthcare providers at these facilities. And what participants are receiving is a package of clinical consultation with PrEP medication that is delivered every 1 month after the PrEP initiation visit, so a 1-month PrEP supply, and then a 3-month PrEP supply at all refill visits thereafter. So first, I'm going to highlight some research that we're doing on adapting the where of how services are delivered in Kenya, specifically looking at models of delivering PrEP services at private pharmacies in Kenya, and also developing and testing a model of online PrEP delivery. So here are findings from our Farm PrEP pilot, which was a pilot study that was ongoing in Kenya from November 2020 to December 2021. And these findings were presented at CROI this past year, and this paper is currently under review. In this model of pharmacy-based PrEP delivery, private pharmacies or trained pharmacy providers at private pharmacies implemented a standalone model of pharmacy delivery where they both initiated and refilled clients on PrEP using a prescribing checklist with remote clinician oversight. In this pilot, we screened 575 clients, and we identified 476 that were eligible for pharmacy-delivered PrEP services. So this means individuals that did not have any medical conditions that might contraindicate PrEP safety, such as history of kidney or liver disease, and then 60% of these individuals initiated PrEP at this setting. On the graph on the right, you can see the behaviors associated with HIV risk among individuals that initiated PrEP at this setting, and you can see a very high prevalence of behaviors such as having partners of unknown HIV risk, inconsistent condom use, multiple sexual partners, and recent sex with alcohol. When you look at the breakdown of these characteristics by male and female participants, you see a higher prevalence of these behaviors among male participants. And when you compare these behaviors to those of individuals initiating PrEP at public facilities in Kenya, you actually see a very different risk profile of those initiating PrEP at the pharmacy, with a much higher prevalence of individuals with multiple sexual partners and partners of unknown HIV status at the private pharmacies. This here shows the graph of PrEP continuation at these private pharmacies among those that initiated PrEP. So you can see continuation rates at month 1, 4, and 7. And over the duration of this pilot study, 55% of clients that initiated PrEP returned to these private pharmacies for any PrEP refill visit. And additionally, we identified 21% of clients that stopped or restarted PrEP, which we defined as returning more than 15 days late for a scheduled PrEP refill visit. And these rates of PrEP continuation are very similar to what you see at public facilities in Kenya. So early findings from the pilot study suggest that private pharmacies can reach a new population at high HIV risk that we're not reaching with traditional clinic-based services. Additionally, private pharmacies, this evidence suggests that pharmacy-delivered PrEP is at high demand with continuation rates that are similar to or exceed PrEP delivery at clinic settings. However, barriers to scale up of pharmacy-delivered services in Kenya remain, including a lack of evidence on effectiveness and costs, as well as some regulatory barriers about the scope of practice for pharmacy providers. But we are doing a pilot continuation study right now where we're testing some implementation strategies to some barriers that were identified in this pilot study. And we are also have a cluster randomized trial that is starting up testing this model in January. This here shows the model of online PrEP delivery that this research team is testing. This is called the EPrep Kenya pilot that is a joint collaboration with Madawa, which is a private online retailer in Kenya, as well as with Japaigo, Otteray, Fred Hutch, JQuat, and UW. And in this model of online PrEP delivery, individuals receive a blood-based HIV self-test, which they upload on the Madawa platform, and then they meet and review the results of that HIV self-test with a remote clinician. And are prescribed PrEP using the same prescribing checklist that we're using in the brick-and-mortar model of pharmacy-based PrEP delivery. And we developed this care pathway in collaboration with a number of Kenyan stakeholders, including the Kenyan Ministry of Health, and we're hoping to start this pilot study this fall. I also want to mention briefly some work that we're doing on when PrEP services are delivered in Kenya. So for this, we did a randomized control trial called the JAPIMA-JAPrEP trial that tested a model of 6-month PrEP dispensing supported with interim HIV self-testing. So 6 months of PrEP were dispensed, as well as 2 HIV self-tests for interim testing at 3 months to reduce the number of annual PrEP clinic visits from quarterly clinic visits in half to biannual clinic visits. And we measured a number of both effectiveness outcomes related to PrEP continuation and adherence, as well as some acceptability outcomes and economic outcomes that are presented in a poster presentation at this conference. This was a 3-arm individual randomized non-inferiority trial where we randomized women in serodifferent couples, men in serodifferent couples, and women not in no serodifferent couples to either an intervention arm that used oral fluid HIV self-testing or blood-based HIV self-testing. And we compared this to standard of care PrEP dispensing in Kenya, which was 3 months PrEP dispensing with quarterly clinic visits. And this took place at a research clinic in Thika, Kenya, which is just outside Nairobi. And here are the primary findings that were just published in Lancet HIV last month. And you can see that across our 3 co-primary outcomes, which was testing for HIV in the past 6 months, refilling PrEP at the 6-month visit, and PrEP adherence at the 6-month visit, as measured by any prevalence of tenofovir diphosphate in dry blood spot samples, we found that these outcomes in the intervention arm were non-inferior compared to standard of care PrEP dispensing. So the main takeaways from this trial were that 6-month PrEP dispensing with interim HIV testing has the potential to reduce the number of PrEP clinic visits in half without compromising HIV testing, retention, or adherence outcomes at 6 months. Additionally, in a subgroup of women not in HIV serodifferent couples, the intervention significantly increased PrEP adherence at 6 months. And we find that this evidence suggests simplifying models of PrEP delivery and using HIV self-testing to support PrEP continuation, and has the potential to also open up other models of community-based PrEP refilling that require less frequent contact with the health system. So I want to acknowledge all my colleagues, particularly Dr. Kenneth Ngure, who couldn't be here today. So thank you.
Yeah, and I just want to give a shout out to Ngure, who I'm sure is online, just who unexpectedly couldn't join us, and we miss him. So hi to Kenneth, where you are. So I think our next input is a virtual one, and I think that'll be coming up now.
Just a reminder that you can still send your questions online. and keep jotting them down.
Hello everyone, I'm going to talk about the DSD for PrEP in Action, Adapting the WHO, Innovations from Brazil. I don't have a conflict of interest, and I would like to begin presenting some key points that I read in a paper published in Lancet in 2020, and I consider this to be related to the way Brazil is conducting the policy. So, for starters, the main message about WHO is that the model of care, centralizing in doctors, restrict access, and the model of care is a barrier to access, especially for vulnerable population. The path is the decentralization of PrEP using task sharing and nurse-led PrEP to improve access for key population and increase PrEP services capacity without additional resources. Nurse-led PrEP also provides great job satisfaction for nurses and allows them to work through a fuller scope of practice. Brazil's approach to PrEP prescription before to changing nursing prescriptions was centralizing a few services only in large urban centers and the metropolitan regions. Does not require medical doctors or specialists to prescribe. And we know also nurses have experience with providing or ordering necessary testing, conducting counseling for combination HIV prevention, and providing complementary services such as contraception and STI management. In 2020, Brazil agreed with the Federal Council of Nurses, called COFEN, to enable nurses to start prescribing PrEP and training nurses with webinars and workshops. We provide a free access virtual course for all prescribers and included nurse-led preprovision in the national guideline. Before nurse prescriptions, nurses were only responsible for PrEP assessment, performing the HIV testing, and providing counseling. They did not take part in PrEP initiation or reinitiation or other steps of care. After adaptation in WHO, the PrEP service provider is with the start nurse-led PrEP prescription, and nurses begin to participate in all other care steps beyond the first action and testing. About a training approach, these options of training are like tools and can be accessed at any moment. It's not mandatory. The courses are short, virtual, with open access, and the same for all prescribers. Not needed to start prescribing. We also developed a phone app for support clinical decision. Here, I'm showing the graphic representing the conference abstract. It represents the percentage of prescriptions since the initiation of nurse-led PrEP. And we can see how much nurse-led PrEP was important to expansion of the PrEP access in Brazil, representing a growth rate of 10% in relation to total prescriptions. Currently, 50% of prescriptions are made by nurses in Brazil. In this slide, we do an analysis about a PrEP user's profile, considering total of prescriptions. In the heat map, it's possible to observe the percentage of nurses' prescriptions in each Brazilian state and the locations where we need to increase the prescriptions, understand the singularities of these places that can be barriers for the nurse-led PrEP, for example, training. Still considering the same analysis, we observe a few variables that represent a distribution with a statistically significant difference when comparing users monitored by doctors or nurses. This slide is very interesting because we can identify that nurses are prescribing more for Black people, people with less years of schooling, sex workers, and drug users. So, starting from the great sample of users that we analyzed, it was concluded that nurse-led PrEP can increase the access by vulnerable population, especially key population. This is very important in Brazil because we have a concentrated HIV epidemic. These results were also presented in the conference abstract, and I would like to share with you. Even though we have started a little while ago, in September last year, during this period of analysis, we observed that primary health care is being accessed by Black population more than it's being used by the white one. Just for contextualizing, today we have an user profile, majority of gays and other white MSCM with a high level of schooling. So increasing access for this population means decreasing inequities. Here I show the expansion of PrEP services in Brazil in each year since the initiation in 2018, when we had 82 reference services. In 2020, a pandemic year, we implemented many strategies for supporting the follow-up of PrEP users with the restrictions by the pandemic, and you can see that on the slides. I would like to highlight PrEP monitoring performed by telemedicine using digital forms, computer or phone, and also self-tests for reducing the clinical visits. On the clinical follow-up, each people can receive up to 5 tests every visit and PrEP for up to 4 months for active users. In 2021, we kept the scale up in number of services and began PrEP prescription in primary health care. In 2022, we already have 473 total services. From the Brazilian experience, it is possible to point out some takeaways. Among them, nurse prescribed and managed PrEP is now inferior, safe, and effective, supported the growth of the number of PrEP services, increased the uptake of PrEP services, and avoid unnecessary referrals. During the COVID-19 pandemic, nurse prescriptions was crucial for enlarging the number of new PrEP users and supports access among vulnerable population. And finally, where to from here, the beginning of nurse-led PrEP opened the doors for increased the DSD actions in Brazil, and now we need increased PrEP services in our country, especially on primary healthcare facilities. Continue to train in nursing, especially where they still do not prescribe, and support the prescription by pharmacies or other non-clinician providers. Begin to offer injectable cabotegravir as option for a specific population, learning from other countries' experience about the possibly delayed cadres for PrEP refill delivery. About this point, we have a good experience with the Live Better Knowing and a community-based strategy to expand the HIV diagnosis among key population. The strategies uses the methodology of peer education and consists of offering HIV tests that use oral fluid outside health services and link users to the services. Maybe we can improve it with the delivery of PrEP. And the last point, start PrEP project to expand the access by trans people, which will be developed in partnership with the Pan American Health Organization in 16 services in the country at the trans outpatient clinics. My acknowledgments, I would like to thank the Minister of Health, especially my director, Gerson Pereira, my work team, the National HIV Coordination, and Anna and Amy for being so caring. Thank you.
Thanks. So we'll shift from Brazil to Thailand.
Okay. Thank you for inviting me to this section. My name is Narutapor Thamataluk. I'm a Senior Program Officer at Institute of HIV Research and Innovation, IHRI, Bangkok, Thailand. Today, on behalf of IHRI, I would like to present on the lesson from the COVID-19 adaptation on what innovation from Thailand. I declare no conflict of interest. All models in this presentation were developed by 3 principles that to simplify, differentiate, and demedicalize. I was assigned to talk about the what innovation, so I would like to focus on the demedicalization. Demedicalization are able to tailor on the provider service delivery side, supporting technology, innovation, skill building method. In this presentation, I will show the example of what model in the Thailand that express and cell collection sampling, telehealth with HIV cell testing, and STI management service and bundle service delivery. First of all, I would like to introduce a quick about the KPLHS or Key Population-Led Health Services. It was designed and co-delivered HIV-related health service by KP, focused on the specific KP such as MSM and transgender women. It has been implemented among 11 community-based organizations, health center, and one IHRI clinic called the PrEP Tangerine Clinic. KP-led PrEP model is the collaboration between the community-based organization and physician at the hospital to serve the PrEP service as a one-stop service at community-based organization. In this figure, you can see that the blue process are conducted by the community-based organization, and the orange are conducted by the physician at the hospital. In this figure, you can see the review blood test and prescribed PrEP virtually will be done by the physician at the hospital. That's all the physician involved in this PrEP service. This model is very effective in Thailand. The data will be shown in the next slide. This model has contributed the largest PrEP data set, which shown in the dark blue and the light blue in this figure. Serving PrEP has covered by universal health coverage since October 2019 in Thailand. And KP-led PrEP can provide the PrEP under KP-led clinic. But the reimbursement must be done in the hospital only. So while 26% of the light blue is from the PrEP KP-led organization as well, because we have a PrEP under the NHSO at this time. Currently, 80% of the current PrEP user is under KP-led PrEP as well. However, over more than 8 years of PrEP implementation, we reached the target only 22% in the national PrEP targeted among the key population. During the COVID-19 KP-led PrEP clinic, we have implemented two models into the KP-led clinic. It's EPrep and Telehealth services. EPrep service is a service delivery that removes some steps at the clinic and use online platform instead in order to provide a shortest time to spend at the clinic for the sample collection only. It's applied for the client who prefer on-site visit. For the telehealth service, along with the PrEP delivery, it is a service delivery that delivers service virtually for the client who are unable to visit the clinic. Looking at the EPrep PrEP service, I would like to give you to focus on the WHO, that the color code at the WHO that you can see that in the black one is for the KP-led provider, in the red one is for the physician or the virtual physician, and the last one is the green one for the client. You can look at WHO and perform what in the next box. In this EPrep PrEP service, you can see that only KP-led provider can be able to complete the majority of the tasks, excepted only the prescribing remote by the physician and client cell sampling for STI screening. The laboratory results for the EPrep PrEP service are shared to the client via email, chat application, SMS, or phone call. It's up to the client preference. This slide, I would like to show that in the left-hand side is a procedure of the EPrep service that implement in the KP-led clinic. And for the right-hand side, we would like to show about the acceptance rate among the PrEP follow-up on the EPrep service were highly gradually after implemented at the KP-led clinic, and especially during the COVID-19. In addition, we found that very high client satisfaction were demonstrated in EPrep service. It's shown in the It's shown in the year 2020, sorry. During the first wave of COVID-19, it was the first time that Thailand encouraged the client to perform the CTN cell sampling by themselves, and we collect about 200 the client to show the acceptance rate that you can see that is very by the anatomical side, 100% for the urine collection, rectum and neovagina, and 80% for the oropharynx. Next model is a telehealth PrEP service. Looking at the building block of the telehealth PrEP service, and we will focus on the who perform what again. You can see that the entire service package is delivered virtually by KP lay provider, with physician provide the virtual script only and the client will performing the HIV cell testing or performing lab tests at the nearby laboratory or hospital that they need to go. And in this telehealth, we implemented the virtual STI management as well. We would like to give the example of a CTN management in the Tangerine Clinic that like a telehealth that when the CTN results are reactive with the symptomatic or asymptomatic, physician will prescribe treatment virtually to the client and follow up in the 7 days via the telehealth. However, if the client has a CTN non-reactive with the symptom, the client will be suggested to see the physician in the person for the further testing. HIV cell testing with PrEP telehealth has been implemented in the Tangerine Clinic since April this year. In PrEP initiation, we start with the pre-test counseling, and then we deliver the HIV cell testing to the client. Client perform their test and then report that test by the post-test counseling, and after that we will deliver the PrEP to the client. You can see that the PrEP follow-up is like the same for the PrEP initiation, but we send the HIV cell test along with the PrEP in the same time to reduce the cost of the messenger, or easy for the client to receive it in the same package. For the bundle service delivery, we top up and add on the CTN cell collection kit into the HIV cell test and send to the client. This one implemented in the Tangerine Clinic in this month, and we perform this one when the messenger send the PrEP, the messenger will pick up the home sampling from the client back to the laboratory as well. In the PrEP follow-up, we added that the counselor will evaluate the client about the list of CTN, or the client can request to the clinic as well that we need to STI screening. For the key message integrated DSD, improve the PrEP asset and uptake through the task sharing from the physician, nurse to the lay provider, express and telehealth service. CTN cell sampling is able to eliminate cultural barrier on the STI screening, especially in Asia. It's address challenge in implementing routine asymptomatic STI screening. HIV cell test can be one key element of the PrEP service during and post-COVID-19 pandemic. It can be combined with other cell tests, cell sampling in order to establish a service option for clients. HIV cell testing is currently not reimbursable under universal coverage scheme in Thailand. This is the key barrier in the scale up. Thank you. Thank you for your paying attention.
Brilliant. Thanks so much. Just terrific innovation, I think, and I hope inspiring to everyone. I know we're starting to run out of time, but I really want to hear both from South Africa and from the Philippines. So I'm going to start with you, Hasina. Would you just reflect on what you've heard? You've got one of the biggest problems in terms of trying to turn off the incidence taps in South Africa. We all know it's extremely burdened with HIV. Do you want to just, for a minute or so, just reflect on what you've heard and how it applies to South Africa? You got a mic?
Let me start off with, firstly, the DSD guidance. And definitely from the South African side, it has helped us a great deal to look at simplifying the delivery of oral PrEP, looking at the reduction of the 7-day lead-out time for people that are stopping PrEP, and we included that in our guideline. The other major game changer is the creatinine clearance, and not doing creatinine clearance testing for under 30s, and that is in our guideline, and the excitement with which that was received, especially with young people. That was the group that found the creatinine clearance and the blood draws very daunting and intimidating, and I think that we will see greater uptake from that point of view. With regard to the self-testing, I'm very excited about that, because I think that would definitely bring us closer to looking at having greater intervals that we will, sort of call people back, and people can manage themselves. The issue on the multi-month scripting, and we started that during COVID, and that has worked quite well. It's now included in the guidance, so after 1 month, after the first HIV test, after the month 1 visit, we give them 3-month scripts and 3-month supply. And I think that has also been a major game changer for us. We've seen in the last year where the PrEP uptake, and we're talking about scale-up in South Africa. And unfortunately, with COVID, we had started our scale-up in October 2019 with the aim of completing it by September 2021, and COVID hit 2020, and COVID hit us. So it definitely did slow down the process. We are now at 68% of our public facilities that are implementing PrEP. And while I hear all of these really useful innovations, implementing oral PrEP in a public facility is a different situation. It's different from our partner facilities. And right now, majority of the oral PrEP is delivered by nurses. It's in our public facility, it's nurse-led, nurse prescriptions. There are some challenges in terms of which nurses can prescribe. And I think that, one of the things that one could possibly look at, especially with the approach that we've taken for non-communicable diseases and chronic diseases, where the reinitiation or the initiation is done by a clinician that is highly skilled and a nurse that has sort of got those skills. However, the continuation, which is the re-prescribing, is not that complex. So those are things that we could possibly explore as we move along. Most important in all of this has been the capacitation of healthcare workers. And, if we look at the building blocks, as much as we say, let's look at which cadre of healthcare worker can provide that service, if you don't provide the tools for people to be able to provide that service, the capacitation, the mentorship, the ongoing support, we're going to fail. And so we've spent a lot of time on making sure that we start with the lowest level of person, the peer educator, the community health worker that goes out and provides that information, provides that support, including them in the training, including the lay counselors who do the HIV testing, who become the gatekeepers for identifying people who may benefit from the intervention, and then looking at the nurses themselves. So these tools are absolutely critical. We now have expanded and moved to the pregnant and breastfeeding women and developed tools for the antenatal services. And then the other critical element in all of this is the M&E system, because you need to monitor what you're doing and making sure that that is properly put in place. And we have got systems in place, but access to information is always a challenge. And we've just launched now a dashboard for oral PrEP. And the exciting thing about the dashboard is that it looks at oral PrEP initiations from looking at every single health facility based on the targets that we've set for them, and then look at the drug availability and making sure that the medication required for oral PrEP is available and it can be monitored through the dashboards as well. So yes, I think it's very exciting to hear all of the innovations, and definitely we will try out many more of those. Thank you.
Thanks so much, Hasina. And then the Philippines, again, have been a showcase for how to do things. Danvik, do you want to just give us your reflections?
Yeah, just additional points, because Dr. Hasina has really placed a lot of insights, especially from the medical perspective. In the Philippines, where PrEP is mostly dictated by the response from the communities, I think it's really important that we have to have some perspectives, especially to involve communities on how we respond to deliver these services. As we always say, as I always say in presentations, we know the market because we are the market. We know the services that we are going to provide because we would want to receive that services as well. And the beauty of differentiated service delivery is that we will be able to adjust what we will be able to roll out in the communities, because this is the beauty of adjusting our services to accommodate the different lifestyle of each and every clients that we want to serve. But of course, this includes the medicalization services, and we will be able to roll out PrEP in multiple clients based on their lifestyle. It's well adjusted to them, and that would make them more adherent and more adaptable, so that they'll be able to ensure that they're always retained. There are many exciting points, especially in the recent release of cabotegravir. It is it's a welcoming option for the communities, but the fear is now, if we are going towards the medicalization, this might go back to remedicalization, because this will involve the use of healthcare personnel. So I think one challenge that we need to ensure, so that we will be able to continue this momentum, is to ensure that communities are still there to adjust how we'll be able to roll out this option, and basically to ensure that if it's demedicalized, at least to provide guidance on how the communities will be able to roll this out in multiple, clients that we serve. Because if we roll out PrEP unstoppably, we can effectively end the epidemic.
Beautiful, beautifully said. Absolutely fantastic. I think you will all agree. I think it's been a tour de force. Sorry that we've not been able to hear your questions, but I know that all of the individuals who've participated today will hang about all day, Robin tells me, to answer your questions on DSD PrEP. And for those of you online, we see your questions. We will gather them, and we'll make sure we get some responses to you as in the course of this week. But I want to just add my amazing thanks to I'm so enthused and excited and energized that we can do this. And I totally agree with you, Danvik. If we get this right, when we come back in 2025, we're going to be able to tell a much more, energizing story of how we've reached our goals. I'm going to hand over to Sarah to close us down. Thanks so much.
Thank you so much. I think as countries really do appreciate the WHO guidance and the IAS, because I think we do want to reach the 10 million target by 2025. So we are going to work on it and make sure that we deliver on the 10 million as much as we can. So thank you for the guidance. Thank you to all the presenters from the various countries and all the experiences from as well as the panelists. So thank you very much. And I want to thank Linda as well for co-chairing the session. So we just want to remind you of several other sessions that are going on. One, we have a session on Monday on the science of differentiated service delivery, and you can see it there. Please tune in. We also have a free online course, which is on differentiated service delivery from the IAS, and you can be able to log in, and there are 4 modules, and you can go through that, and it is free. Finally, there is a compendium website that contains tools and evidence endorsed for use by national HIV programs and countries. So please use these resources. We thank you so much for our fruitful discussions. As well, there's a roadmap there for the AIDS 2022. So thank you so much, and thank you for participating.